Greetings and welcome to the inaugural session of The Right Dose. My name is Ruth Ackerman, and you are getting the very first time I've ever done a Zoom webinar, so pardon all my errors, but it's going to be really great. We have a great speaker tonight. So with me today to moral support and for lots of other things is Liliette Davidson. Liliette is on our executive team at the Ontario Pharmacists Association, and she is the Vice President of Business Management and Development. Liliette.
Welcome to our very first live webcast education series, The Right Dose. I want to first start off by saying how this shift to this virtual online world has really become a reality with many new normals for everyone. And for me, it meant making the shifts and changes around the home with my kids homeschooling and everything. So I'm actually adjusting to sitting here in my office, and my family bathroom is right here. So it really makes things interesting in evening webinars and so forth.
Yes, Liliette, I can totally relate. Working from home, it's been an adjustment for all of us, and but a pretty nice commute.
Lucky you. The other night, actually, true story, the other night, my 8-year-old daughter, Sinead, was in the bathtub right here playing with her Barbies. And her Ken doll was in the bathtub along with her Barbies, and Ken was diagnosed with COVID. Well, actually, she said, "Ooh, Ken has COVID." And so all her Barbies are now self-isolating in her bedroom, and Ken dried up in the bathtub when she had let the water out. So I can't make these things up. This actually did happen.
That's funny, kids. Well, Liliette, tell me a little bit about your vision for The Right Dose.
So my vision for The Right Dose is a platform to bring our professional development to many in a convenient fashion where traditional learning has likely changed and shifted forever. With this format, you'll be able to learn, get connected, stay informed with all that is pharmacy profession, technology, and business related. This first session is complimentary for members and non-members this evening. Going forward, it will be a members-only event.
So as a pharmacist, I can totally relate at how busy our practices are and how busy life can be. The Right Dose will have a regular schedule with great topics and just the right dose so that we can respect our busy schedules but still get what we need to continue to lead care in our communities. Our guest speakers will include experts from Canada and from outside of Canada. We may be inviting members from within our executive team to share what's going on at OPA. If you have any topics of interest or would like to be one of our experts, please reach out to us through education@opatoday.com. And before you go, Liliette, I just want to see if I can switch this to the next. It's not working there it goes. If you can't hear anything, you need to dial from one of the phone numbers. Everybody's on mute. And if you have questions, please put them in the Q&A. Liliette.
Awesome. So we have well over 100 people and approaching 200 people tonight, all here to get more information on the science of COVID. And we are so pleased that all of you could join us tonight. So this evening we have Dr. Sherilyn Houle from the University of Waterloo School of Pharmacy and Dr. Naomi Floria from Care Choice Concierge Medicine in California. Dr. Houle and Dr. Floria will begin the conversation with the discussion on the current status of the science of testing. Then we will hear from Justin Bates, our CEO of the Ontario Pharmacists Association. Let me first introduce Dr. Houle. Dr. Houle received her Bachelor of Science in Pharmacy degree from the University of Saskatchewan in 2006, and she gained practice experience in hospital and home care practice in Alberta prior to returning to graduate school in 2009. Throughout graduate school, Sherilyn practiced in community pharmacy, including practicing with additional prescribing authorization and authorization to administer injections. Upon completion of her PhD in 2014, Sherilyn became a faculty member at the School of Pharmacy at the University of Waterloo. In this role, Sherilyn teaches in the professional practice series, including coordinating the injection training aspect of the curriculum and conducting research related to pharmacists as immunizers, as well as travel medicine practitioners. Sherilyn also practices at the International Travel and Immunizations Clinic associated with the Center of Family Medicine Family Healthcare Team in Kitchener.
All right, thank you very much, Liliette. I
You're
am
welcome.
thrilled to be here today to facilitate this very, very timely conversation. So first, I would like to introduce Dr. Floria. So Dr. Naomi Floria was an associate professor, vice chair of innovation, and director of professional experience programs and global health initiatives at the University of Southern California School of Pharmacy. Of particular note and relevance for tonight's talk, she holds a specialty in infectious diseases, having completed a postgraduate pharmacotherapy research fellowship at the Center for Anti-Infective Research and Development in Hartford, Connecticut. She has also served as faculty and chair at Loma Linda University School of Pharmacy from 2003 through 2015. In 2018, she co-founded Choice Care Concierge Medicine, where she serves as a chief pharmacy officer. Her focus at Choice Care is on providing comprehensive medication management to the patient population served by this concierge medical practice. So before we hear from Dr. Floria, again, just want to thank all of you in advance for submitting any questions in advance. We will try to address those after her talk, and any additional questions that you have, feel free to ask those in the Q&A box at the bottom of your screen. So without any further ado, let's get started with Dr. Floria. And let me advance my slide here. Okay, so Dr. Floria, my understanding is that there are several different types of COVID tests. Can you start off by explaining for us what those are?
Yes, absolutely. First of all, thank you, Dr. Houle, for the warm introduction. Thank you to Ruth and Liliette for putting on this type of educational programming. It's a topic that everybody wants to talk about and is talking about. So let's get to the question. So the different types of COVID testing available. Let's talk about these. You have three types of COVID tests available. There's the molecular test, the antibody test, and the antigen test. Let's look at each one of these individually. The first test that was developed and is considered the gold standard for diagnosing a patient with SARS-CoV-2 is the molecular test. The molecular test is a reverse transcription PCR test. And the scope of this test is to obtain a sample, usually obtained through a nasopharyngeal swab, which we'll discuss in later slides. But you obtain a sample, usually through a nasopharyngeal slide, and then you analyze that sample to identify the presence of viral RNA. It's the molecular test, the reverse transcription PCR, is extremely specific to this particular virus, to SARS-CoV-2. It's essentially identifying viral RNA. You obtain a sample, you amplify it, and you're looking for sample of this virus. Is this virus present, yes or no? Since, let's say, February, November, this really has been the entire focus of testing. It has been identify if the virus is present in a particular patient and diagnose that patient with this virus, SARS-CoV-2. So it's a diagnostic, and it has been considered the gold standard for diagnosis, and it has been the sole focus of testing until about April. In April, we now had the launch, the development, the proliferation to market of a second type of test, and that's the antibody test. Now, an antibody test is a blood test, and it looks for the presence of antibodies in the blood. Has the patient been exposed to SARS-CoV-2? And if so, has the patient mounted an antibody response? Do they have the presence of IgM in an acute response? And do they have the presence of IgG, a more delayed response that will give you more prolonged immunity? And that's the antibody test. Blood test identifies or looks for the presence of antibodies. On May 9th, we had a third type of test that came to market. And the third type of test was the antigen test, available again on May 9th. And the antigen test specifically looks for viral proteins. It is specific to SARS-CoV-2, identifies or looks for these viral proteins of SARS-CoV-2. And the reason it is used to diagnose, just like the molecular test, the PCR test, the antigen test is used to diagnose. Now, why was this test developed? Why was an antigen test developed? The antigen test was developed because the PCR, the molecular test, although gold standard and identifies viral RNA, one of the rate limiting factors was that the turnaround time was quite long, hours to days. And so the antigen test was developed to give you a more rapid turnaround time, give you a diagnostic test, just like the PCR that's diagnosing patients, but the turnaround time is 15 to 30 minutes. That's why the antigen test was developed. So you have three types of tests. The molecular test, which is the PCR test, it looks for the presence of viral RNA. The antibody test, which is a blood test, it looks for the presence of antibodies. Now, to go back on this topic, it looks for the presence of antibodies, IgM and IgG. It is not diagnostic. This test is not used for diagnosis. It is used really in seroprevalence studies. It tells you in a given population, you can sample a given population, and it will tell you what % of that population has been exposed to the virus and has mounted an antibody response, has mounted IgMs and has mounted IgGs. And then the third test that was most recently developed is your antigen test. It is used for diagnosis. It specifically identifies a viral protein specific to SARS-CoV-2, and it was developed for a more rapid turnaround time in diagnosis. Next slide, please. To look at some of the nuances. So to reiterate, there's of the three types of tests, there's two that are diagnostic. The molecular test, which is your PCR, your gold standard, and the antigen test, the latest that looks for viral proteins. Both of these are highly specific for SARS-CoV-2. They're highly, this is what they're intended to do. They're intended to identify the virus itself. The PCR test, although rate limiting that it has a slower turnaround time, is more sensitive. Both of these need a really good sample. You need to obtain a good nasopharyngeal swab. The antigen test, however, is less sensitive. So you need a better sample for the antigen test than you even do for the PCR test. So that's something to keep in mind when you're sampling. If you're doing a nasopharyngeal swab, for both you need a really good sample. You need to be trained well, but the PCR is actually more sensitive than the antigen test. So you need a very good sample for the antigen test. In terms of the PCR, that molecular test that's diagnostic, one of the nice features about this is that you can identify, it can test positive up to a week, 7 to 10 days before symptom onset. So that's very important. Again, very specific to SARS-CoV-2, and it allows you to detect symptoms 7 to 10 days before the onset of symptoms. The antigen, on the flip side, although more convenient because there's a more rapid turnaround time, doesn't allow that type of flexibility. It can only detect a positive test 5 days after the onset of illness. So 5 days post symptoms is when an antigen test will usually give you the most accurate reading. The result turnaround time for PCR, the molecular test, the diagnostic molecular test, is hours to days. Really, if we look at historically since February, March, it's really taken days. So that's a rate limiting factor for this particular test. The antigen test, diagnostic, specific to SARS-CoV-2, has the nice feature in that it has a more rapid turnaround time of 15 to 30 minutes. We move to some nuances on the serologic test, that's the antibody test, the blood test that looks for the presence of antibodies. Has the patient been exposed to this virus, and has the patient been able to mount antibodies? Are they able to mount IgM? Are they able to mount IgG? This particular test really allows you, it helps you determine if patient has had a prior infection, perhaps has immunity if the IgGs are positive. The specificity and sensitivity are lower. So when we get into some of those nuances, we'll talk about false positives and false negatives. With the serologic test, these antibody tests, it is detectable 7 to 10 days after the onset of illness. So the only one that you can test a week before even onset of symptoms is your diagnostic PCR. The antibodies will be positive or are viable, are accurate only 7 to 10 days after symptom onset. The beauty of these drugs, the value of it is that they have a very rapid turnaround time. It's really minutes, and it's extremely practical. It's an extremely practical test. Next slide, please.
Well, thank you very much for that overview of the different types of tests that are out there. Now I'd like to hear your expertise on the different types of specimens. What are the differences between them, and what are the different methods that are available for specimen collection?
That's a really great question, and it's something that as pharmacists we need to know. So again, let's look back. We have 3 tests. We have our molecular PCR test, our antibody test, and our antigen test. For the 2 diagnostic tests, which are the molecular PCR test and the antigen test, the method of collection is typically most common via the swab, a nasopharyngeal swab, and then the antibody test is a blood test. Next slide. Let's take a look at this in a little bit more detail. So you have a few options. Again, the diagnostic, the PCR, and the antigen, you're going to obtain respiratory samples. The most common will be your nasal, or the gold standard really is the nasopharyngeal swab. So you have this long swab, you insert it in the nostril of the patient, you twist it around for about 15 seconds, you pull it out, insert it in the other nostril, again, deep down into the nasopharynx, you twist it for 15 seconds, and then you have your sample and you send it to the lab. You have to be aware that due to sensitivity for both the PCR and the antigen test, you need to be skilled and trained in obtaining a nasopharyngeal swab. I'll tell you why. The reason why you hear, I'm sure you've heard it in literature, you've heard it on the news, you've seen the publications. These nasopharyngeal swabs, and you have your diagnostic PCR and antigen test, oftentimes will give you false negatives. Now, why is that? They're highly specific. They're identifying the virus itself. They're looking for the viral RNA. So why are you getting false negatives? The reason that you're getting false negatives is because of poor sampling. And that's something that's extremely important. As pharmacists, when you move into the arena of sampling patients, you will need to be trained. You will need to practice because a poor sample will really drops the sensitivity. And if the sample isn't appropriate and you don't have a good sample, you have false negative rates of up to 30% with swabbing. So that's extremely important. A false negative of 30% is unacceptable. We can all agree it's unacceptable. And so as pharmacists moving forward, if you will be testing, if you will be sampling patients, you need to be trained in technique of nasopharyngeal swabs. Nasopharyngeal or oropharyngeal swabs can only be done by healthcare providers. That's important to know. And again, proper training is important so that you don't have false negatives. Another respiratory sampling method is a nasal mid-turbinate swab, also called a deep nasal swab. This can only be performed by a healthcare provider. A patient can perform this if it's under direct observation by a healthcare provider. And it's variations on the same theme. You're not inserting the swab as deep into the nasopharynx, but it still requires some skill. The anterior nares specimen is a nasal swab. This anterior nares specimen or a nasal swab can be done certainly by a healthcare provider. It can be done by a patient under direct observation. It can also be done by a patient at home. So your home testing kits will utilize this type of method, which is an anterior nares specimen or a simple nasal swab. Respiratory specimens can also be obtained through a nasopharyngeal or wash, an aspirate or nasal aspirate, and that can only be done by a healthcare provider. The last mode of sampling for the upper respiratory tract is via saliva. Rutgers University developed both a laboratory as well as an at-home testing kit utilizing saliva samples. Next slide, please. If your patient is symptomatic, highly symptomatic, is coughing and is able to produce sputum, the sputum of a patient can also be sampled. Again, for both the PCR as well as the antigen test to identify the virus. If the patient's intubated, you can certainly do a bronchoalveolar lavage. pleural fluid, lung biopsies. These are all options for patients that are hospitalized, intubated, etc. Next slide, please. Serology. Serology is different. So we talked about the PCR and we talked about the antigen test being based on respiratory specimens, usually via swabs. Of those, the nasopharyngeal swab being really the gold standard or the most commonly used. For serology tests utilize blood. So either a venipuncture, so you can draw blood and send it to the lab. You have Roche and Abbott that run serology tests. You can also do a finger stick, point of care testing done via finger stick, rapid, convenient. Both of those are done by healthcare providers. As of yet, there are no in-home test kits for antibody or serology testing. Next slide. We discussed this slide in the past two slides, and it's just those sampling methods that can be done by a healthcare provider via those that can be done by a patient. The only two that can be done by a patient exclusively for at-home testing would be a simple nasal swab or a saliva test. The rest have to be done by a healthcare provider.
Great, thank you very much. So now that we know the different types of tests and the different types of specimen collection, can you please walk us through when you would use each type of test?
Yeah, that's an important question. So let's take a look at all three of these individually. The molecular test, or the PCR test, is the diagnostic test that can be used up to 7 days before symptoms. That's important. The antibody test, you need 7 days post-exposure, post-symptoms for it to be accurate. And then the antigen test, you need 5 days post-symptoms, post-exposure, post-symptoms for it to be accurate. Let's take a look at this next graph. This is an important graph to understand. You take a look at the blue line, that's a nasopharyngeal swab using the molecular test, the PCR test, and as you can see, you can detect beginning a week prior to symptom detection. It peaks right about a week or a few days post symptoms and then declines rapidly. If you look at the dashed purple and dashed green lines, the dashed purple line is your IgM antibody. The presence of IgM antibodies, which will be the first antibody that is detected, signaling an acute reaction or acute response. As you can see, you need 1 week, 7 to 10 days post symptoms for it to mount. It peaks at about 10 days and then declines about 2 weeks thereafter. The IgG, again, you need a week post symptoms to mount a response. Peaks about 10 days post symptoms, and the IgG is your antibody that then lasts for a prolonged period of time. It is the antibody that you're hoping will confer more prolonged immunity. If you look here, we have a data that shows that you're still maintaining response or maintaining levels 6 weeks post-infection. The latest study that came out of Nature that was published a week ago actually found that it looked at 37 patients and it showed that they maintained their IgG response, a strong IgG, 3 months post-symptoms. It appears ongoing studies are still required. It appears that there may be some waning immunity. The IgG starts to drop after 3 months. That'll be important, and that's an ongoing study and discussion. Next slide, please. This slide is variations on the exact same theme, just a little bit more in depth in terms of IgM mounting a response 7 days or a week post symptoms. And then the IgM drops thereafter, 2 weeks thereafter, with the IgG beginning to mount, again, 7 to 10 days post-symptoms, and an IgG that remains prolonged over 6 weeks, and we know at least until 3 months. Next slide.
All right, thank you for that. So now that we know about the different types of tests, What are the testing criteria for the use of the diagnostic test? And is there any role for using those tests in people that are asymptomatic?
That's a great question. Let's take a look at IDSA guidelines. We'll look at the IDSA guidelines, that's the Infectious Disease Societies of America guidelines, and then we'll look at the CDC guidelines. For symptomatic individuals, so symptomatic meaning what? What are the symptoms that a patient with SARS-CoV-2 would have? They would have fever, fatigue, lethargy, cough, shortness of breath, GI symptoms, nausea, diarrhea, loss of smell, loss of taste. Those are hallmark symptoms for these patients. So if a patient is symptomatic, and you have a high suspicion of COVID, you must test they're essentially prioritized for testing. So if a patient's symptomatic, they are prioritized for testing, and the tests that need to be administered are the diagnostic tests. What are the diagnostic tests? Your PCR and your antigen tests, swabs. Those are diagnostic. If you have a negative finding, so patients who are symptomatic, let's say you do your PCR, you do your antigen, you're trying to diagnose these patients. If the test comes back negative, you need to retest. Why do you need to retest? You need to retest because of that potential 30% false negative in the event that there's poor sampling. So you need to retest. If there is low suspicion for COVID, then the guidelines say not to retest. As a clinician, I would retest. If they're symptomatic and they test negative once, certainly if they're high suspicion, you retest. If they're not, you have the choice of retesting or not. For asymptomatic individuals, there's a big talk. There's asymptomatic individuals. 50% of people 40 to 50% of people will not have symptoms. So who should be tested if they're asymptomatic? If the patient has been exposed to a known COVID positive patient, so if they've been exposed, they should be tested. If they're on immunosuppressive therapy or have an immunosuppressive condition, they receive priority for testing. Certainly for major time-sensitive surgery, it's important to test, and that's been one of the reasons why we've had, not the only reason, but one of the reasons why we've had a spike in cases is that you have asymptomatic patients who are resuming their medical care, who are going in for their elective procedures. They must be tested for COVID, and a lot of those asymptomatic patients are asymptomatic but were positive. If a patient has been around an aerosol generating procedure, that certainly also warrants testing despite them being asymptomatic. If we look at, next slide, if we look at CDC, on your right-hand side, CDC has priority for 3 groups of people. The CDC gives high priority for patients that are hospitalized with symptoms. So if the patient has symptoms and is hospitalized, high priority. They must be tested. What test are you going to use? You're going to use the PCR or the antigen for diagnosis. Who else receives high priority? Healthcare workers, workers that work in congregate living facilities, first responders that have symptoms, they also receive high priority. Who else receives high priority? Category number 3, residents in long-term care facilities, congregate living facilities, prisons, shelters with symptoms. So what's the people with symptoms? Either they're hospitalized or they're in extremely high risk environments. Healthcare workers, congregate living facilities, prisons, those people receive priority, high priority. Priority would be people with COVID symptoms, really anyone with COVID symptoms or anyone that is deemed, any person prioritized by their physician, their public health department. The CDC has a criteria for asymptomatic patients. Again, similar to IDSA, if they've been in contact with a known COVID positive patient. If in their particular community or jurisdiction, there's a high prevalence of COVID-19 or SARS-CoV-2, they get priority for testing, although they're asymptomatic. If they're in a nursing home, long-term care facilities, and there's rampant spread, they also get priority even though they're asymptomatic. and healthcare personnel that are even mildly symptomatic. If they have a sore throat, they're nauseous, they also receive priority, even though they're considered perhaps asymptomatic. Next slide.
All right, so we hear a fair amount recently, especially about false negatives and some variable performance in the different diagnostic tests that are out there. Can you spend a few minutes talking about some of the limitations of these tests?
Absolutely. So the diagnostic test, we'll talk about the limitations of the diagnostic test. It's really something that everybody wants to talk about. How accurate are these tests? What's the sensitivity? What's the specificity? Can I trust the results or not trust the results? So let's talk about the diagnostic test first. So the diagnostic test will be your PCR or your antigen test, the ones that you obtain via a nasal swab, a nasopharyngeal swab. So how sensitive and how specific are they? We talked about them being very specific. These are tests that are specific to SARS-CoV-2. You're identifying either the viral RNA or you're identifying the viral protein. So they're very specific. So in terms of specificity, that's where we're talking about false positives. Sensitivity is when you're discussing false negatives. In terms of sensitivity, there's one main factor, to reiterate, the one main factor that will make them less sensitive, less specific, will be poor sampling. So false negatives refers to the sensitivity, okay? So what's going to give you a false negative? The number one driving force behind a false negative from a diagnostic test, a PCR or an antigen test, will be improper or inadequate specimen collection, right there in the middle. Improper or inadequate specimen collection will be the driving force for poor sensitivity that will give you a false negative. Other factors that come into play that will give you false negatives: if the sample is obtained too early, perhaps maybe 2 weeks before symptom onset, or 10 days even before symptom onset. We saw that 7 days is really what you're looking at before symptom onset. So anything that's too early or too late could give you a false negative. There was also a big issue. It was in the headlines all over the media talking about Abbott's test. It was used in the White House, among other places. And so there was this big kerfuffle that we had false negatives with Abbott's PCR test. What was that all about? They really came to a conclusion. They were transporting, the media that they were transporting their swabs in was diluting the samples. And so that's why you were getting a false negative. Other than these reasons, the number one reason will be an improper or inadequate specimen collection. If you're not getting a good nasopharyngeal swab, if you're not trained and you can't get it a good swab, then that will drive down the sensitivity and it will give you more false negatives. And again, up to 30%. False positives, we talked about, this is specific. This is highly specific to this virus. So there really shouldn't be any false positives, correct? Well, there was about 300 patients in Korea, as well as maybe a dozen plus cases on the USS Roosevelt. And these are patients that had SARS-CoV-2, they were treated, they recovered, they tested negative, and then they came back and they were positive again. And everybody was completely shaken. This is nerve-wracking. Are people getting reinfected? What is happening? The Korean CDC came out, they studied these patients. They studied them on the USS Roosevelt as well, and about a month ago they came out with the results. And what they found is that these patients that tested positive again were false positives. What does that mean? That means that the test, hello, am I still on? Hello?
Yes.
Can you hear me?
Yes.
Okay. I lost this slide, but I'll keep talking. So these patients, again, were positive, treated, resolved, tested negative, and then they come back and they test positive. So the Korean CDC, USS Roosevelt, they looked at these patients, and what they found was that the virus was present when they would swab their nose and look for the presence of virus. The virus was present. But what was interesting was that the virus was inactive. So after the infection resolved, the virus was actually inactive. It was not active virus, it was inactive. So for clinicians out there, if you're having these issues, and we've had this issue in our practice where patients are test positive, are treated, symptoms resolve, and they keep testing positive, we actually request that the lab then looks at the virus and tells us, is this virus active virus or inactive virus? So that will be your area where you can get false positives. The virus is there, but it's inactive. Next slide.
Wow, that's some very interesting stuff. So let's shift gears a little bit and let's talk about serology tests specifically.
Right.
So for example, how is the technology for a serological test different than a PCR test? What do the results of an antibody test really tell us? And what do we know or not know at this point about the presence of antibodies?
Perfect. Just before we move on, I seem to have lost my slides. I don't know if the audience can see the slides. Maybe someone can chime in. I don't know, Dr. Houle, if you see the slides.
Yes, I do.
You see the slides, okay.
Mm-hmm.
Oh, there we go, I have them. Okay, perfect. Okay, so let's talk about serology tests. So we talked about the diagnostic PCR and antigen, we talked about the swabs, we talked about how you sample and their limitations and pros and cons. Okay, let's talk about serology. So serology tests are these antibody tests. It's a blood test, and you are looking for the presence of IgM antibodies, IgG antibodies. You have a few methods of sampling. We talked about venipuncture, and you can take the blood sample and send it to a lab. Really, the two best ones right now are Roche and Abbott that are running the serology test. They have very high specificity and very high sensitivity, and it's an ELISA-based lab test. You also have these lateral flow assays, point of care testing. They almost look like pregnancy tests, and it gives you results within minutes. It's something that you can do in a clinic. It's a finger prick. You place a drop of blood, a solution on it, and then it tells you, it really looks at the presence of IgM or IgG antibodies. Some depending on the test that you're using, some will report IgM, IgG, others will just give you total antibodies. Are there antibodies present, yes or no? The vast majority, the overwhelming majority of these tests will tell you the presence of IgM and the presence of IgG antibodies. Next slide. Okay, so what do these serology tests do? They detect the presence of IgM or IgG. We talked about IgM being present and elevated in the presence of a more acute infection, with IgG being present, status post-infection once the infection has resolved, and maintaining its presence for at least 3 months post-infection. It is used, serology tests are used to determine the presence of prior infection. So that's why they're so common, that's why they're being used in seroprevalence studies, looking at a group, a population of patients, and identifying within that population how many patients have been exposed to this virus and have mounted antibodies. We talked about them being detectable 7 to 10 days post-symptom onset. Extremely practical in that they give you results within minutes, especially those point of care testings are very practical in clinic settings. IgMs develop first and then IgGs follow and may indicate that a patient has acquired immunity. Next slide. Fascinating study by Long and colleagues published in Nature at the end of April found that in addition to seroprevalence studies, there may be an additional role, and the use of serology may be used as an adjunct to come along diagnostic tests. If a patient is testing, it has a PCR result that is negative, so is negative but is suspected, there's strong suspicion for SARS-CoV-2, then a serology test may be used as an adjunct to come alongside that test and see, is there perhaps a false negative with the PCR test. It's also certainly used, it's considered, I guess the gold standard, the only thing to do in surveying, identifying asymptomatic patients and a population as a whole. Next slide. So big discussions. You hear this all the time. It's all over the place. How reliable are these serologic tests? how sensitive are they? How specific are they? So let's talk about the most specific and the most sensitive. We talked about Roche and Abbott. The Roche has a specificity greater than 99.8%. Abbott's specificity is greater than 99.6%, and they both have a sensitivity of 100%. What does that mean? That means that these particular serologic tests were developed to detect only SARS-CoV-2. So they're highly specific for antibodies to SARS-CoV-2. There's no extra noise. There's no extra non-novel coronaviruses that this test picks up. In terms of sensitivity, it can detect the absolute lowest level of antibody presence, and it's 100% sensitive. So these are these are the best of the best, right? You get your blood samples. If you're using these, you send the blood of the patient to the lab. What about these other tests? What about these point of care tests, these finger stick tests? A lot of people are using them. The FDA has about 200 emergency use authorizations issued for serologic tests. So they're being used widely in the United States. If you look at the tests that have emergency use authorizations by the FDA, their sensitivity and specificity on average is about 95%. 95%, meaning most of them will range in the 90s. On average, it's 95%. So that gives you a little bit of room for noise, a little bit of room for error. So let's talk about false positives. That has to do with specificity. Because they're not 100% specific for SARS-CoV-2, you're going to have some noise there. So you might have some false positives in patients that may have non-novel coronaviruses, so other coronaviruses. If a patient has another type of coronavirus, there's a 5 to 10% chance that that your serologic tests will pick this up and it'll be a false positive. Specificity, false positives will come from detecting a different strain of coronavirus that is not SARS-CoV-2. So that's specificity. Sensitivity, when can you get false negatives? So the patient is infected, but your test is negative. You're not detecting IgM and IgG. When can that happen? That can happen if the patient has antibody levels that are too low. It's important to keep that in mind. Very important to keep that in mind. A Nature study looking at 37 patients last week published that 50% of asymptomatics will not mount an antibody response, or if they have very mild symptoms, they may not mount an antibody response. That's why it's not diagnostic, so keep that in mind. So false negatives are possible if they have very low levels of antibodies. Not everyone infected will develop antibodies. That was also identified in several studies, but certainly the latest is the Nature study published last week. Or if they're sampled too early. Remember, you need 7 to 10 days post-symptoms to be able to see these antibodies on a test. Next slide. In terms of, so what does this mean? So we have these antibodies. What does this mean? What does this mean? Everybody wants to know, it's the million-dollar question. So I test a patient. The patient has maybe had IgMs, now has IgG positive. What does that mean for a patient? Let's look at what it means. So let's look at the different evidence that we have so far. The very first study that really sought to answer this question started in March, and it was looking at monkeys, the infected monkeys with SARS-CoV-2, and they've been trying to reinfect them now for months. As of today, they have not been able to reinfect those monkeys with the coronavirus. The monkeys that were originally infected, they have not been able to reinfect those monkeys. What about the Korean patients? That was all the rage. We talked about the Korean patients. They made national headlines. 300 plus Korean patients were they reinfected? No, these patients weren't actually reinfected. Those were false positives. They tested positive again, but the virus was inactive, not active. So as of date, whether it's patient data or animal data, we don't have evidence of reinfection. We don't have evidence of reinfection. However, we also don't know how long an antibody response will survive. You know, it was a little bit daunting, you know, in Nature, again, last week's publication, 37 patients, to see that there may be some waning immunity 3 months post-symptoms, post-exposure and post-symptoms. That really remains to be determined. How long will these antibodies be protective? That's a question that remains to be known. And so can we say that once a patient's been infected, they will have lifelong immunity? We can't say that. Can we say that they, should we give immune passports? Well, we can't say that, because the bottom line is we don't know. We simply don't know. As of now, we still need more time to see, once these patients have these antibodies, how long will those antibodies be protective? Right now, the answer is we don't know. It looks like 3 months. Will it be more than 3 months? That remains to be determined. Next slide.
Wow, that's very interesting. It seems like we've come a very long way in a very short period of time in terms of understanding the virus, but like you said, still have a lot more that still has yet to be determined.
Right.
And let's shift gears one more time. So far, most of the presentation has focused on healthcare professional administered tests.
Right.
What are the options for home tests or patient self-administered tests?
Okay, great. So in the United States, we really have 3 tests. We have a Pixel by LabCorp. We have the Rutgers Clinical Genomics Laboratory test, and then Everlywell developed a collection kit, an at-home collection kit. So these tests are all, they're all diagnostic. They're all based on a PCR test, and they all allow a patient to sample in home. The Pixel by LabCorp is a nasal swab. Again, the nasal swab can be done at home by a patient. The Rutgers test is a saliva test. It's the first of its kind, and so patients send in a sample of their saliva to the lab. And then the Everly home collection kit is a nasal swab. Again, what is authorized for a patient to be able to do at home. If you look at the general flow, next slide, if you look at the general flow, and again, the purpose of these tests, these are at home, they're not blood tests, these are nasal swabs or saliva, and they're diagnostic tests utilizing a PCR or an antigen to diagnose, to look at the presence of virus. Is the virus present, yes or no? So the general flow would require, is as follows, next slide. The general process is patients will order online, can order their tests online. It's usually delivered within 24 to 48 hours. Of note, the Rutgers test requires a physician prescription. The other 2 can be ordered by the patient online. Once there's an online screening, once the tests arrive, there's an online screening for symptoms. The patient has to register their kit, and they receive a unique kit identification. The patient then either does the nasal swab or the saliva and returns the sample to the lab via FedEx or UPS here in the United States. The lab provides results within 48 hours, and if the test is positive, they have a telehealth consultant that contacts the patient and discusses the next steps.
Wow, that's very interesting. It kind of reminds me of the saliva test that you can do for ancestry or DNA
right
test, the self-collection that you throw in the mail to get your results from. Very interesting. Right. But finally, can we wrap up by just having you talk about your experience with offering COVID tests and maybe some advice that you have for pharmacists that are thinking about perhaps offering this in the future?
Right. So I think this is a topic and then kind of the slide that's dear to myself, and I think every pharmacist wants to talk about these issues. What do you do? Let's say you're charged, and I've now done countless tests, whether it was a nasopharyngeal swab on a patient or a serologic test on a patient. I've done countless tests, and kind of reflecting on my experience with this, what are some of the take-home messages? What's important for a pharmacist? Number 1, you need to be able to assess the patient. The patient's coming in, they're going to be sick. They're not going to be feeling well. You need to be able to assess their symptoms, know what the symptoms are, know the virus, know what the symptoms are associated with this virus. Fever, fatigue, shortness of breath, difficulty speaking, cough, loss of smell, loss of taste, GI issues. Be very familiar, be able to identify and know a patient's symptoms. Know their risk factors. Are they healthcare workers? Do they work in congregate living facilities? Do they work in a prison? Do they work in a nursing facility, a nursing home facility? Know their risk factors, know the level of exposure that they've been exposed to. Remember, high viral loads are dangerous, and these people may or may not have been exposed to very high viral loads. So first and foremost, you need to know the virus. You need to know the clinical presentation of the virus, because a patient will be coming, they will be standing in front of you, they will be scared, they will have symptoms, and you need to be able to identify those symptoms, understand those symptoms, identify their risk factors, understand those risk factors. The second thing that's extremely important as a pharmacist, as any healthcare provider, is your own personal safety. Personal protective equipment for myself is non-negotiable. It is absolutely non-negotiable. This is not something, a test can wait until you have proper personal protective equipment. An N95 is not negotiable when you're standing within a few, within a foot, 2 feet of a patient and swabbing them or doing a blood test. So an N95 is not negotiable. A face shield is not negotiable. Protective gown is not negotiable. So those are things that as a pharmacist, if you are asked to do this, and I think it's an important role that you can play in managing this pandemic, you have to protect yourself. So that's very important, and discuss it with your employers, or if you're an independent pharmacy, start preparing yourself. I'm sure you already have been, but prepare yourself in the event of a simple face mask, a surgical face mask won't suffice if a patient is symptomatic and you're testing them and within a foot of this patient. So that's important. The next, so patients come in and they're standing in front of you, you're assessing them, kind of as you're looking at them, you're already assessing, you understand, you start assessing their symptoms, you start assessing their risk factors, you're donned with your personal protective equipment because that is non-negotiable. Everything can wait. You really need to be protecting yourself. Now you test them. So we've gone through, maybe you'll do a nasopharyngeal swab in your pharmacy. Maybe, depending on what Canada's legislation is, maybe you'll be able to do a point of care blood test to test for antibodies. So you're doing the testing. And what you're going to have to realize is that you're going to have a very clear strategy if the patient tests positive. You need to know where to report your results. So you have to inform yourself in terms of for us, we report to the Department of Public Health within our city or our county. We report, so you need to know where will you be reporting these results. You need to have a very clear plan for the patient. If they're testing positive and they're sitting in front of you, you need to realize that for many patients, this for them is like receiving a death sentence. They're terrified. Many start crying. A lot of them are anxious. They might even have a panic attack in front of you. You really need to be prepared in delivering the news and having a strategy for this patient. What do you do next? Who do you send them to? What advice do you give them? What treatment options are available that you can discuss? And then follow up if necessary. Who are they going to follow up with? Do they come back to the pharmacy to get retested? Those are questions that you will need to prepare for. The last thing from my experience is you need to know the literature. You need to be prepared to answer questions. Patients will have a myriad of questions from prognosis to treatment and everything in between. You have to know the literature. If you're starting on this path of testing, you're going to need to have a plan for the patient, be able to answer questions, and know the literature. So those are things I said.
Yeah, that's certainly a lot to think of and to prepare for if this does come down the pipeline for us. So in terms of what's going on right now, I'm just going to spend a few minutes talking about what the current state is here in Ontario and in Canada, I guess a bit more broadly. So we're right now in a much earlier stage of approving point of care tests in Canada. Right now, there's 2 devices that are Health Canada approved that are point of care tests versus being laboratory tests. One of them received quite a bit of positive press initially. It's called the Spartan Cube test. It then got some negative press when there were some issues realized with its swab. So that one is considered approved, but only for research use until those issues are resolved. So practically speaking, there's one product right now that's currently fully Health Canada approved for non-research purposes. There's nothing in the application packages for either of these devices that says a pharmacist can't do it, but what we are limited by is our provincial legislation and what's within our scope of practice. And anybody who has dug into the legislation on this will attest that it is very confusing. It is very hard to wrap your head around, so I will try my best to summarize it relatively straightforward. So essentially, in terms of specimen collection here in Ontario, a pharmacist cannot prick a patient's finger unless it's for educational purposes. If it's for the purpose of a diagnostic test, it's considered outside of our scope unless we have delegation from another healthcare professional to do it. It's also considered outside of our scope to do a nasopharyngeal swab, but we can perform a nasal swab. When it comes to communicating results of the test, we can provide an interpretation of the test result, but we cannot consider that to be a diagnosis. The act of diagnosis is considered a controlled act. We would have to have that, again, delegated to us in order for us to do it. So the confusing thing for many pharmacists is, well, how come I can prick a patient's finger to test for their blood sugars if I'm teaching a new diabetic patient how to use their glucometer, but I can't do it for this purpose? And the distinction is that pricking of the finger can happen if you are educating the patient on how to self-monitor for a condition. As soon as we need a blood sample for a pharmacist's assessment, then that's when it's considered outside of our scope without delegation to have. So as I said, this is quite confusing stuff. For those of you that would like additional information, I do encourage you to visit Pharmacy 5, the number 5, in5.ca. If you haven't already done so, one of their modules is specifically on the legislation about point of care testing in Ontario. So please do visit that website. Again, that's pharmacy5in5.ca if you'd like some additional clarification on this. So next we will hand things over to Justin Bates, who is the CEO of the Ontario Pharmacists Association. And he will be discussing with us the background and involvement of OPA on this subject of pharmacist testing for COVID-19. And following his remarks, we will have our question and answer session. So Justin, off to you.
Well, thank you and good evening, and appreciate the introduction. Dr. Floria, you provided us with a lot of insightful information as it relates to COVID-19 and pharmacy's potential role. When I think about all of the things that are happening, this is a really exciting time for pharmacy, and these are really important conversations to have. And I'm excited for this type of platform to certainly extend the conversations and learn about what the advantages and some of the challenges are to operationalize things like point of care testing in pharmacies. In terms of the broader environment in Ontario, OPA has been doing a significant amount of advocacy as it relates to scope of practice, including looking at the ecosystem, all the different considerations that need to be included as it relates to COVID-19 testing. One of the things that we're doing as a step in terms of mobilizing the grassroots and advocating for pharmacy professionals in the province is we're launching an awareness campaign. And that awareness campaign is to celebrate the great work that pharmacists have been doing during the pandemic and before and after, and also to highlight from a government relations perspective the core advocacy initiatives that are underway. As you saw 2 weeks ago, the ministry posted on the registry draft regulations to enable pharmacists to inject the flu vaccination to 2 and up from the current threshold of 5 years old, as well as the ability to extend a prescription up to 12 months. In addition, there's the ability now to, once passed, the regulations will allow for the administering of injections beyond for educational purposes. And even today, and Dr. Houle, you've highlighted some of the challenges and barriers from a regulatory and legislative perspective. But just before our webinar, the government posted on the registry new regulations that would essentially allow for the collection of specimens from their patients for the purpose of performing point-of-care testing, as well as the ability to do the point-of-care testing for medication management of certain chronic conditions, including things like blood glucose, hemoglobin A1C, and lipids. So we're starting to see the advocacy and the expansion of the scope of practice really support the idea of the pharmacist as being a central hub or a community healthcare hub. And I think that's really important, as we always maintain the core of the dispensing services and medication management. But when we look at the patients and the patient needs, it's going to be critically important that we continue to play an even greater role in serving patients in that transformation from augmenting from the core dispensing services into things like point-of-care testing. This will be the future of healthcare, and we have a great opportunity to pivot from where we are today with the appropriate considerations and criteria in place. We also have minor ailments coming down the line very quickly, with the college putting their recommendations that have been approved by the council to the minister later this month. And the anticipation would be that the government will post the minor ailments regulations at the end of or beginning of July for public consultations. We're ensuring that as we see all of this scope of practice, that we're also advocating for all the supporting mechanisms that need to be in place in order to implement the various scopes of practice. And that includes funding. You know, we're not going to be working for free, and we need to make sure that there's appropriate and adequate funding for all of these things, including in the potential environment of having the ability to perform COVID-19 tests. When I think about some of the opportunities as it relates to supporting the government in their efforts to reopen the economy and also to protect public health, and how we can leverage our expertise and our high accessibility with over 4,600 points of care as pharmacies across the province, we put together in the last 60 days, working with government after they asked us for a solution to help them increase their testing capacities in the assessment testing centers, we put together a 3-point plan. The first point in the plan was to have exploratory and preliminary discussions with government around what a testing role for pharmacies and pharmacists would look like. And we put that forward with the concept that we still need to do some consultations with both our members and the broader pharmacist community. But we thought it was important to engage with the ministry and engage with the minister's office, health minister's office, and premier's office on how we could be part of a solution. We understand some of the anxieties and fears around how would this be operationalized, that we have to address some of the workplace issues that with any of the scope of practice need to be discussed. And we are doing some of those things. We are meeting on a regular basis now with the Ontario College of Pharmacists and other stakeholders to address some of those workplace issues to ensure we can have a smooth implementation, whether it's COVID testing or any of these scopes of practice that are currently in play in the future. We've also looked at the criteria of funding. What would that look like? We've certainly looked at a couple of ranges in terms of ensuring that the tests are covered, the performance of the test is covered, as well as the assessment. So those discussions are ongoing. And Dr. Florea, you mentioned the importance of having the personal protective equipment. So, you know, it's certainly underpinning all of this would be access to the PPE. This isn't going to be for everyone or for every pharmacy, and I think that's really important to underscore. As we go through these discussions and we look at the regulatory and legislative components, whether it's for COVID-19 testing or the broader point-of-care testing space, we need to make sure that we understand that it's optional. Certain models will work better than others. When we looked at the PCR testing, whether it's the antigen or the diagnostic molecular side, and the point-of-care serological testing, we looked at it from an asymptomatic patient perspective. Our role would be to look at the PCR testing, more of a outside the pharmacy environment that we've seen operationalized in some of the states down south. But we've also looked at the opportunity as the tests become approved by Health Canada, and there's a number of applications in the queue, of what that would look like from an operational standpoint in the store. So there will be many stages to this. There's certainly a lot of different considerations that need to be taken into account. But these are important conversations to partner with government and offer opportunities for the pharmacy professionals in the province to really step up and provide exceptional and optimal care to patients. We don't have all the answers yet, and that's why we're having sessions like this and really going through this process to understand the risks and the benefits. And I think having the facts laid out about what the types of tests are and certainly what our potential role can be is a critical part of understanding where pharmacy will be, both with this particular pandemic, COVID-19, but beyond that too, and what the opportunities and how they will present themselves. So with that, I would open it up for Ruth, back to you for the questions and answers.
Thank you, Justin. I think based on the timing, we're running a little late. Let's just get the answer to one question that seems to be popping up. Naomi, you talked about when you did a nasopharyngeal swab that the swab had to be done in both nostrils.
Yes.
I don't think that's the experience that some people are getting in Ontario. Could you comment on that?
My only comment is, so I guess the only comment would be, and again, I don't know exactly, what's being used in that given area. My only comment would be the sample has to be a strong sample. So one of the reasons we're doing 2 nostrils is to obtain as strong of a sample as possible. Again, because we're running into that 30% false negative, which is unacceptable. We're trying to get as strong, a robust of a sample as possible.
Yeah,
So
well,
I guess that's the only take-home message. Whatever, again, whatever test you're using that's approved, and of course follow that methodology. I would never say, to follow something other than that. But the test that we use requires 2 nostrils, and it's again to get as robust of a sample as possible.
That's great. I wondered, one of the ones that I thought was very interesting was, could you comment on the vaccine development, considering that we can't, the immunity can't be guaranteed by the antibodies? That's a brilliant question. That's a brilliant question. It's probably the $3 billion question, probably if not more than that, right? Maybe $100 billion. That's exactly what's happening. And if you look at the Oxford study, and if you look at the Moderna, the two, I guess, the biggest contenders for coming to market the soonest, is they haven't been able to produce neutralizing antibodies. And if they're with the vaccine that they're giving. And so if you're not able to produce significant neutralizing antibodies, there's a problem with that. And you have to really take a look at that issue. Yes, we're trying to rush a vaccine. Yes, they're trying to rush a vaccine. Yes, they're looking at early 2021, but that's in vain. We're not even going to get to discussions of safety if we can't get to the discussion of neutralizing antibodies. And this virus is, it's tricky. It's interesting. It attacks T cells. It destroys T cells. When you attack and you destroy T cells, well, down the road, your antibodies also get impacted by that. And so I think we're starting to see some of that where antibody response is not as robust, not as prolonged as we would hope. RNA viruses in general, it's difficult to have prolonged immunity. With RNA viruses, with influenza, we have 12 months. After 12 months, with SARS, we had 2 years. After 2 years, immunity wanes. Part of that is, yes, the virus mutates, but the other part is the antibodies itself. Here, regardless of, with SARS-CoV-2, regardless of mutation of the virus, the antibodies themselves don't appear to be as robust and as prolonged as we would hope they would be. So that's a brilliant question. And that's something that as a pharmacist, you have to be well aware of. You need to know the data and say, hold on, will this confer immunity? Is it able to produce neutralizing antibodies? And so far, the 2 top contenders, the data isn't strong.
It's actually quite concerning.
And Justin, we had a question about you made a comment about recent changes to scope of practice. Does it include throat and nasopharyngeal swabbing as part of our scope of practice? Are you aware?
So it's early days. It was just posted about an hour before this webinar started.
Sorry.
Yeah, and it doesn't have a lot of detail, but what I can tell you is that it looks like the regulations will allow for, within the Labs and Specimens Act and the Regulation 683, for the purpose of allowing pharmacists for the purpose of collecting specimens from their patients to perform point of care tests. So some interpretation there, whether that's more on the serological side, piercing the dermis and getting some blood samples, or if that will allow for the nasal or throat swab. So we need to confirm that. Our proposal that we submitted to the ministry and to the Premier's office last week detailed out really 2 phases to this. Phase 1 being in the immediate and short term, which would be around the diagnostic molecular and antigen testing that would allow for that to be done outside the premise, but with all of the protective equipment and protocols in place. For that to be enabled, they would require those changes to the Labs and Specimen Act. So it looks like this is consistent with that, but we need to confirm. But certainly what we're seeing here with the registry posting would allow for the point of care testing on the serological side. So the antibody testing, and it will go beyond COVID, of course, to tests like INR, A1C. So regardless of the detail, I think this is a very positive step for pharmacy professionals and an acknowledgement from the government of the important value that pharmacists have to the healthcare system, that we need pharmacists to play a greater role in public health as well as medication management.
And I would be remiss if I didn't ask you, Dr. Floria, about what sort of training a pharmacist would require in order to be able to do these tests. If you could just summarize. You're on mute.
Yeah. So, I personally trained with an otolaryngologist. I think it was important to get, the highest level of expertise that I would be able to obtain. But depending on what setting you're in, certainly if you're working for maybe a chain, they would have to have a training module or program in place. And if not, you'd have to take it upon yourself and really find your best resource. So I had to take it. We started doing this in early March. There were no training modules or programs, and so I sought out the assistance and the training from an independent physician, an otolaryngologist, that was able to train me. So,
well, that makes sense. Pharmacists in Ontario, when they were granted the authorization to do immunizations, there were certificate programs that we took, which were both online and also in-person programs. So that's likely what we're going to see in Ontario, so that somebody can watch you and make sure that you're doing it right. Get the scope enabled first, and the permission, and the reimbursement, and then we'll likely be able to do it. I want to thank everyone for coming today. This has been amazing. Lots of people attended. I'm sure that we have a ton more questions and answers. We received questions ahead of time. You answered a lot of them, Dr. Floria, so that's great. And but I will be sending something out. And thank you everybody for coming. And we're excited that for the next one. And just to let you know, look for your inbox. We'll be sending you a follow-up email to let you know, to give you a little survey, give you a little bit more information, and on the next one that's coming up. So I appreciate it very much, your attention this evening, and have a great evening.